Welcome to The Explainer. Okay, picture this. A client walks in and tells you they have a herniated disc. Another one mentions their knee has been bugging them. So, what do? Well, your greatest tool in these moments isn't the reformer or the Cadillac. It's your knowledge of anatomy. Today, we're cracking the code on how to safely and, more importantly, effectively teach clients with some of the most common injuries you're going to see. First up, we're going to lay down this single most important principle that guides, well, everything we do. Then, we'll open up three really crucial case files: the pressured disc, the slipping spine, and what I like to call the blameless knee. And finally, we'll wrap it all up with the golden rules that are seriously going to transform your teaching. All right, so before we dive into any specific injuries, we absolutely have to establish the one core philosophy that underpins every single decision we make in the studio. And here it is. The crucial point is that our primary job isn't just to make people stronger, it's to keep them safe. Our anatomical knowledge is basically a shield. We use it to modify movements and respect contraindications, making sure we never, ever worsen a client's condition. Safety is always priority number one. Okay, let's open our first case file. And this is a big one, something you are definitely going to see, if you haven't already, in the studio: the herniated disc. So what's actually happening here, anatomically speaking? Well, just imagine those soft little cushions between your vertebrae. A herniation happens when the gooey, gel-like center of that cushion pushes out through a tear in its tougher outer layer. Now, the real trouble starts when that bulge begins to press on a nerve. And yep, this happens most often in the lower back.
This right here lays out the clear danger zones. You know, the number one enemy of a herniated disc is rapid forward bending, what we call flexion, like in a roll-up. It just jacks up the pressure inside the disc, pushing all that material backward. But the absolute worst-case scenario? Combining that forward bend with a twist. That creates something called shear force. It's this grinding, tearing stress that's just incredibly destructive. So our whole strategy, as you can see, is to counter this by keeping a neutral spine and zeroing in on deep core stability.
In this analogy, just illustrates the whole concept brilliantly. Imagine that disc is a little donut. If you press down on the front, that's your spinal flexion, the jam is going to squirt out the back, right? So our job as instructors is to be the protective little box around that donut. We use those deep core muscles like the transversus abdominis to create a natural corset that stops that donut from getting squashed in the first place.
All right, let's move on to our second case file and see how this all builds. Now here, we're not dealing with a pressurized disc. We're talking about a vertebra that has actually become unstable and is slipping forward over the one right below it. So here's the breakdown. It often starts with a tiny little stress fracture in a part of the vertebra. Then, that fracture can allow the entire bone to just slip forward. See, this isn't a disc problem. It's a structural instability in the spine itself.
It's a whole different ballgame.
For this condition, the verdict is in, and it is non-negotiable. The number one danger, as you can clearly see, is extension, any kind of backward bending like in a swan. This creates a shearing force that actively encourages that vertebra to slip even further forward. So for these clients, spinal extension is completely off the table. We even have to modify things like leg raises because tight hip flexors can tilt the pelvis and just make that instability even worse.
This analogy is just perfect. The spine is like a tower of Jenga blocks, and one of those blocks is already halfway out. Bending backward is like giving that unstable block another little nudge. So, what's our job? Before we even think about moving, we have to apply strong tape, and that's our deep core muscles to hold that entire Jenga tower together. For this client, stabilization is an absolute lifeline.
Okay, pay attention, because this slide is absolutely critical. What's dangerous for one of these conditions can actually be safe, or maybe even therapeutic, for the other one. For a herniated disc, flexion is the enemy. For spondylolisthesis, extension is the enemy. This is precisely why getting a correct diagnosis from a medical professional is so incredibly important before you design any program. You have to know which enemy you're fighting.
Okay, for our final case file, we're going to shift our focus away from the spine and head down to the knee. But here's the twist. We're about to discover that when a client has knee pain, the knee is often just the victim. It's not the real culprit at all.
So, let's ask the key investigative question right now. When that client complains about an aching knee during footwork on the reformer, where does the problem actually start? Is it really the knee? The investigation reveals that the real issue is almost always upstream, at the hip. The knee is just taking all the heat. When the glute muscles, especially that gluteus medius that stabilizes our pelvis, are weak, the entire leg falls out of alignment, and the knee joint is forced to compensate, which leads to pain and wear and tear.
So our strategy here is crystal clear. First, we have to respect the knee's design. It's a hinge, not a ball and socket joint. That means all rotation has to come from the hip. Second, we manage the load by limiting those really deep knee bends. And most importantly, our focus shifts away from the quads and onto the glutes. We have to cue glute activation first to fix the alignment right at the source of the problem.
And this just perfectly illustrates our solution. The knee is that stressed-out middle manager who gets all the complaints. But the real problem is the boss, the weak hips, who isn't doing its job of stabilizing the pelvis. Our solution isn't to just tell the knee to take a break. No, it's to train the boss, the glutes, to finally step up and do its job properly.
So now that we've investigated these three very different cases, what's the common thread? What's the secret clue that connects the disc, the vertebra, and the knee? Let's distill everything we've learned down into your final takeaway.
This is it. This is the ultimate principle, the absolute foundation of teaching safely. Stabilization must always come before mobilization. Whether we're protecting a disc, supporting a slipping vertebra, or trying to align a sore knee, the very first step is always to create a stable, protected center. The core is the ultimate protector.
And this brings us right to your 4 golden rules. 1. Stabilize first, always. 2. Respect the anatomical limits of the specific injury. 3. Modify everything and never, ever force a movement. And 4. Address the true culprit by looking upstream from the site of the pain. If you apply these principles, you won't just keep your clients safe, you'll truly empower them.
Which leaves us with this final thought. You see, understanding contraindications isn't about learning a long list of movements to say no to. It's about gaining the expertise to find a smarter, a safer, and a more effective yes. It completely transforms modification from a limitation into your most powerful tool for empowerment.